just saw a patient, a golfer, who came in because he wants to know about a 3-level cervical fusion because his MRI shows degenerated discs that are bulging out. After talking to him and obtaining a detailed history, he's still working and he can still play golf, but he did have an episode of pretty significant pain a few months ago, and that's resolved. And then I did a detailed exam, watched them walk, tested his reflexes, among other things, and I'm really glad he came in because he does not need surgery. And I have a lot of patients like that. They come in, they have MRI findings, and they immediately want to know about surgery. So what's the deal with that? What typically happens is that they have an episode of pain, and sometimes it can be significant because spine pain is bad. They tell their doctor, they eventually get an MRI, and that MRI report is pretty scary. Lots of degenerative discs, maybe some disc herniations, maybe some protrusions, maybe stenosis, maybe facet arthritis, and maybe even kyphosis or scoliosis, things that sound very pathologic. And they may have even seen a doctor during the time when their pain was pretty bad and been recommended surgery. And even though their pain is better now, they're worried that it's going to happen again. They're worried that it's going to be a problem in the future. And most people just want to fix things when they find out about it. And in many things in life, that's a good idea, but not when it comes to the spine. Because the spine is really weird in that way, and I suspect this happens in other areas of medicine, but in the spine, there's lots of people walking around with little to no symptoms, and if they get a free MRI to see what's going on, many asymptomatic patients will have all kinds of weird abnormalities. This is really well known, this is really well accepted, and it's been published multiple times in the peer-reviewed literature. This is not a question. It's sort of like wrinkles. Wrinkles are just a reflection of age-related changes. They're not pathologic. There's no disease associated with wrinkles primarily. And many changes in the spine that we see on X-ray and MRI are similar to that. There's age-related changes that are normal, and the body has an incredible capacity to accommodate. And for most of those patients, it's not pathologic to the point that it requires surgery, because spine surgery is kind of scary. And it should only be pursued if it's the least worst option. Now, what's amazing is that the frequency of these abnormalities on MRI in asymptomatic subjects, in other words, in patients or in people that have no significant spine pain, is really high. And if you just need a simple way to remember it, it roughly tracks with your age. So if you're 50 or 60, it's 50 to 60% likely that you'll have degenerated discs, disc bulges, disc herniations, facet arthritis, or some combination thereof. So imagine you're 70. Most 70-year-olds that have no significant spine problems, if they get an MRI for one reason or another, a lot of abnormalities will be found. It is really difficult to tell, just on looking on the MRI, what's pathologic and what is kind of asymptomatic normal changes related to age. We look at several different images all at the same time, cross-referencing all the different cuts. So check this out. This is an MRI of a cervical spine in somebody around 70, and this is what we look at. This is what we call the T2 sagittal image. It's looking at the spine from the side. This is the front, this is the back. You can see this is the jaw and the mouth. Look how big the tongue is, by the way. And this gray rope here is the spinal cord and the dinosaur bones that are in the back. And you can see the base of the skull right here and the back of the neck. And then this image is the bologna slice cross section. And if I scroll up and down, you can see this yellow line to the left moving up and down. And I don't know if you can tell, but there is at least 1, 2, 3 levels of disc protrusions. And if you look at the axial image to the right, this is the neuroforamen. So the spinal cord is right here in cross section. This whole thing is the spinal canal. And remember, the spinal cord is about the size of your pinky, hanging down the spinal canal, surrounded by cerebral spinal fluid. So The white is the cerebrospinal fluid. And then each nerve to a particular part of the arm goes out the side. This is called the neuroforamen. There's neuroforamen on both sides. And in this patient, you can see that there's some left, this is the left side, neuroforaminal narrowing with a broad-based disc protrusion eccentric to the left. Here, there's a smaller disc protrusion more to the right. Here, a smaller disc protrusion but with an annular tear. And things like this can cause neck pain and radiculopathy, which is like the form of sciatica, but in your arm. And a patient like this may have right-sided radiculopathy. That's C5-6. It would go to your 6-shooter, your thumb and index finger. And at C6-7, on the left side, if you have radiculopathy and nerve irritation, you may have symptoms going down your neck, your arm, to your middle finger, because C6-7 affects the C7 nerve root and it gets its own finger. But guess what? This patient does not have any of those symptoms. And that's a classic example of patients that have apparently significant problems that we might have to do surgery on, but in the absence of correlating symptoms, surgery in this case would be, well, it'd be silly. Now, here's the hard thing. An MRI like this, you can see in a patient that is in miserable pain, have all kinds of neurologic symptoms, and would benefit from surgery. But it's hard to tell between that and an MRI from an asymptomatic individual because they can look very similar. So how do we deal with this problem? Well, I think of it like this. One of the most important things that you can do as a spine surgeon to get good results is to establish an accurate anatomic diagnosis. In other words, what is really going on and where is the pain coming from? And to do that, I think of it like a puzzle with multiple pieces, and the more pieces that you have filled in, the cleaner the picture is. If there's only one piece, it's really difficult to figure out what the puzzle looks like. So we're constantly trying to fit in all the different pieces. And those pieces involve things like the patient's history. What types of things bother them and how does it bother them and what is the nature of their symptoms? Is it just like arthritic pain? Is it nerve pain? Do they have weakness? How does it affect their function and quality of life? Their physical exam. They may also have a multitude of other studies like EMGs. They may have other physicians that have examined them in addition to the imaging studies. We rely very much on the imaging studies because without that, we don't know exactly where things are anatomically, which for a surgeon is really important because think about it, surgery is an anatomic fix for an anatomic problem. So if you don't have an anatomic diagnosis and know anatomically where the problem is, you don't know where you're going to operate. And remember, the spine has not just one joint, it has multiple joints throughout the neck, the thoracic spine, and lumbar spine. And there's a disc in the front and two little joints in the back called facet joints, and all through it are running nerves. So you can imagine how complicated that can be. So you have to be really thoughtful and have one of those really suspicious minds where you're just turning over every rock to make sure you're not missing anything. And then when you decide about surgery, you also have to take into account a few other factors. First is, what are the demands and expectations of the patient? What are they trying to accomplish? So a golfer, they want to go back to golf, they want to go back to work. But some other people that are more sedentary, maybe they're older or maybe they just like reading, they will have a whole nother set of goals. And you have to take that into account because there's no such thing as a surgery that has no risks. Everything has a risk, and we're always trying to balance the potential benefits and the potential risks. So all that goes into this puzzle, and we're filling in all the pieces. And by having the best picture of what's going on clinically, can you then list all the different treatment options, and then you start listing them in order of like least worst. And that takes into account a bunch of other factors. And it can get kind of complicated. And there's lots of different ways to come to the final conclusion. But I find it easy for me most of the time when I ask the question, what would I do if this was me or my beloved family member? who I had to sit across from at every major family event and dinner party and holiday. And if they didn't do well, or I didn't do a good job for them, they would just give me the stink eye all night. And I can't handle that.